talking
recorded.
about? This side of the table?
Yeah, this side of the room.
Why?
The other side is not recorded.
How do you know?
Because I looked into all these videos like online, and they're all recording this side. And that's probably why they asked us to sit here.
That's just evidence of your attendance.
What are you talking about?
I was looking at
this
which
side of the room is the only side that's being recorded.
Oh, you looked at a recording.
I look at a recording.
You don't see this side
You know,
of the room.
in the morning, it's this side, so everybody who's eating and everything is recorded, and then when the lecture starts, it will be this side.
I don't think we actively switch anything.
You mean the audio or
No, the video.
Oh.
There's two of them.
Where's the camera? I didn't even realize there was a camera. I thought it was just on here.
No, it's video.
Morning.
Morning.
Lectures, I think they're just audio.
The lecture to count, they only they will never show the speaker at all. So they only show the slide.
Oh, sorry.
So our patient yesterday, they gave her 20 of IBD. Her rate came down and discharged her. Her labs were fine. Just a
Do you have
surface
any
cleaner.
trick-or-treaters?
Her BMI
Not yet. Did you get them?
No, I'm not talking about me tonight. You get any?
No, we get about 12. We don't.
Yours should be a good neighborhood.
They gave her.
Not that many. I've got a reasonable number. I bought 2 bags of chocolate, let's say that.
Okay, that's.
And I hope I don't eat too much of it.
But I think she got discharged.
No, I must admit, I opened 1 bag yesterday and ate a few on the way home.
We just get just the kids in our cul-de-sac, and that's about it.
Normally, I would be in costume, but I'm off today, so I'm not working in any office.
What, that you are always in costume?
Well, like right now. Remember, this is being recorded.
Oh, that's right. That's true. They already started.
I was wondering why they started recording like half an hour before.
Mm-hmm. No,
I know
that
they
is true.
start
Why did they
early.
start so
It's like
early?
20 minutes.
What?
The recording.
I don't know. I don't know. Let's ask Drew when he shows
Just
up.
to get some.
Drew must get here awfully early, because I was here like 6:20 this morning.
Mhm.
He had the room already all set up, and it's off in his office.
Yeah.
I think he comes in by bus.
Yeah, he does.
Yeah.
He tries bus.
Does anybody use the parking garage? No?
That's why we're here so early.
Yeah, to find.
Try to get a place on the street.
Even this early, it was hard.
Yeah.
Well, you said Dexter is
Dexter,
okay?
it's always like pretty open. It's like just 1 block up, and there's not.
It's metered, but
It's metered,
but you just ignore the meter.
Yeah.
Meters start at 8. You're right, and I think I'm a chicken. I put in about $1, so that I don't have to get back to the car till like 8:20 or so.
But it's
Then
usually.
they have the 10-hour meters, and you have to put in a minimum. In other words, you have to buy a lot more time than you want on the 10-hour meters. But you won't click off until you give it, I don't know.
I've never seen a 10-hour
Yeah,
meter.
on some of the streets it says 10 hours, and like if you put in $1, it'll say that's not enough. It wants you to buy, I don't know how
10
many
hours has
and-
to be $20. It's it's usually $400 an hour around here.
Yeah, I guess.
It's
then
got to
you
be a
have
lot. I just
you
have
have to
never
use-
seen a 10-hour.
You have to use a credit card then, and not
Yeah.
have a pocket full of quarters.
When are you going to Hawaii?
We're going to go earlier this year and come back before Christmas, or on Christmas Day.
Oh, is that right? So you're going
Because
before?
someone wanted to rent a place for a lot of money, so we gave it up.
Mhm.
I think we go on the 11th or
Oh,
something
you
like that.
do go early. Yeah.
Yeah, just like this, unless you.
Oh, yes.
I didn't notice that before.
It's the only time of year I get interested in baseball. You been watching the World Series?
Yeah, I'm not a big baseball fan. The Mariners aren't in it. But no, I have watched the last few innings of these games, and they're exciting.
I can
Yeah,
like
they're really exciting.
so much better.
And I mean, most of the year I could care less about baseball. But this is, it's 7 games only, and everyone counts. And
I will get
the
the
guys who announce the games can make it amazingly exciting, just with their speaking voice, just their demeanor.
Yeah, I know, it's been incredible. The relief pitching has been terrible, and these are teams that have great relievers.
Yeah,
Just
home
get
runs
bombed.
is more home
So
runs
did
in
you
this
look
series
at
than in any
subject?
previous whatever.
Reading the new Immunity chapter, but it's more of like an overview. I think the other chapters get deeper into it.
Oh, were you there with the
It's still
boat?
in the basics.
Still in the basics.
The information for you.
Yeah,
We were
but
there,
so much
we were
better.
rafting. So
But I think it's like,
we weren't
I
right
found it
next
like
to the
these
dock. We
people
were
genuine,
on the
like,
other side of one,
chapters
so she may have missed it. She was looking for a boat right on the dock.
What's the name of the boat? She asked me.
Seafari,
But, I mean,
SEA
colleges
Fari,
online, so
Seafari.
if you go to the college
He
website,
went shopping over at
they
University
have,
Village and was just
like
walking
these,
back.
like the way they structure it, even
they were
your
there.
book is based on the
I
class.
figured you'd be there.
So whatever you read in a
Yeah, no, it's an absolutely spectacular day. Weekend. Oh, this week has been beautiful. I actually went up to Mount Rainier on Sunday. Yeah, well, I had to pick up somebody in Packer, which is just south of Rainier, and it was just amazing how beautiful it was up there. Again, you don't see these kind of beautiful falls very often.
I think tomorrow is the last one we're going to have.
Are you where you halfway to the
No,
Yeah, that's true.
See, I got a cup. One thing, yeah.
Maybe after I'm done with it, like I would not understand
Insulin requiring food here.
If she found her boat, here's what she would have seen.
So then you still racing around in your system?
We could miss that.
But we were one boat over.
Well, I don't race.
I was the captain of our ship, so
One of my
been at it a long time. But here,
She's very meticulous.
friends,
we dressed up the boat bit for hell.
and her husband are in graduate engineering programs. Yeah, and she's an automotive engineer, so she's
Here
spent
is not for near. It's just
2
incredible.
months
Color.
in Germany.
It was crystal clear. It's just, I didn't know the foliage could be that spectacular in the fall. Oh, it was my brother.
Oh, really?
We didn't like it.
Bunch of them have all their drivers.
No, he came out and was funeral actually. Which is just
So how do I sign up for that? That would be, think about a cool gig, that would sort of be it. I didn't realize until,
Yes.
Matthews.
Yeah, I was here. I was the caller representative. I was sitting on the second level.
Adam
Interesting
and
and
Blazers,
very
but
thorough.
I-
she's got her posters up there, she's saying
I saw that.
So I just wanted
missed
to
the
give
one
you an
of
accolade there.
Other than that, I've times 3 of them been before.
So it-
Spectacular picture. No, I haven't done that. This is about lives, you know.
great, I'll learn about that.
No, I can believe that Matt's young, vigorous.
You did the climbing when you were young and vigorous.
Well, 45. I was 45 when I climbed. I thought I was old at that time because in our group there were about 30 of us. And I would say there was 1 or 2 guys older than me. So everybody was younger. 45 were young. We took a course. Well, we actually took the course about 2 or 3 weeks prior. One day they take the
Theirs is Wednesday.
show you how to use ropes, how to use ice axes, what to do if you fall, how to self-arrest. So yes, it's a mini course.
we left you.
And then we signed up 3 weeks later.
So neat.
So, yeah, it was fun. You can still do it. It is a workout. It's one of the most rigorous days I've had in my whole life as far as the energy consumed.
It's fun. Last time I looked at them last
anything else from?
Yeah, no, I had a very cordial conversation. We're exchanging information.
Good. So it might turn into something good.
No, I was impressed with the guy, and he showed interest, so we'll see what happens. He may be partner.
Get here early enough. By 6:15 it was already.
For a very brief time before you retire.
Yeah.
They must have access to parking.
They should be expecting myself as long as they do.
So that means
Yeah.
This Husky player, look at this. He's 30 years old and just died. He's one of these huge guys, you know. He's a lineman. He was a very good defensive player for the high school football coach over in Hawaii. I see there are two possibilities. Probably.
Right.
Keep your comments to yourself. No, keep your comments to
Star,
yourself.
high school, college.
Let me point out why.
Everyone else.
Point out why.
They said yeah. Also, maybe diabetic, and all these guys are type A. Although it's still pretty young, being with diabetes, diet complications. Been playing golf?
A little bit, not much.
That sounded laugh. I don't know what to make of that. You would not call it golf.
We got some really nice days. I've gotten out.
Oh, spectacular this weekend.
Yeah.
No, it doesn't get any better than the fall of this past weekend.
Yeah.
The Husky game was incredible, you know, just the weather and the trees, the colors, is magnificent this year.
And they're winning.
And the winning.
Which makes it a lot better.
They have lost one, but
Yeah, it would be like, they came in the middle of one fall.
So we don't have to sign into the.
No sign.
No sign.
No sign.
so now we can get started.
Yeah, that's right.
Same sense of talk.
Sean Leno was up in Mount Rainier.
Wow, that is
Isn't that incredible caloric? You know, when they're running, I hiked around.
Oh,
I couldn't believe it.
You're not gonna go in?
maybe one disease that gets by
Yeah, no, it's not one disease that has a spectrum, but it's a spectrum of disease.
Finally.
It'd be like,
I would get super.
the thing is, like, you were at some work.
They didn't give it any silverware this year?
I mean, that's that target.
No, it's okay.
Yeah, Mary.
Yeah, I know.
So Drew, are you gonna like the new cheat? You're gonna like the new cheat? So you're impressed that they hired her?
But it's just, I think, it's just substantially like 5%.
Oh,
5%.
works, yeah.
But it's, usually
I've seen 5.
yeah.
There's that way by our boat. It's up in the
Yeah, few times left.
That's appropriate.
Again, talking about it more.
You know, Leland was supposed to meet us there, and he just never showed up. And I said, "There's a picture." I said, "There's me waiting for you for so long."
I mean, they have to, because people are, no. I guess it's more.
Yeah, oh, huge crowd. We had about 30 of them. Anyway, so that'd be a good picture.
Yeah, well, that's.
Kids all in college.
But it's hard to believe it, ironic. But I guess you can limit.
Yeah, that's true.
So I think that's the way it works.
They make it hard work. That's amazing.
And the only way you win.
You see this? He's a Husky
No,
football player. Yeah, no, but you know, like I said, the problem is you could have diabetes or something.
some of the genes
Right.
There's always two.
Unless it was keto acid.
What do you think of the Seahawks running attack this weekend?
Well,
No,
so
it's terrible. This guy's
2 yards halfway through the what time was it? That was awesome.
I didn't see
That guy who was doing really well, did he get hurt? That's kind of rolls. My niece used to
All right, let's go ahead and get started.
I know.
He left in another Marshawn Lynch.
Yeah.
These things are captivating, you know, when they beat you have to look at them, right? There's a law now in Honolulu, if you're walking across the street, looking at your phone, you can be fined. There's people get in accidents all the time. Anyway, that's got nothing to do with today. Jamie Rosenthal, our first-year fellow, is going to talk about the spectrum of mast cell disease.
Hey everyone. I consider dressing up like a mast cell today in honor of Halloween.
Oh, tell them that the word of the day is mast.
Oh, the word of the day is mast.
Mast?
I couldn't figure out how to dress up like a mast cell, so I didn't. But I thought about it. Alright, no disclosures. So first I'm just going to talk about two cases, two different patients I've seen in residency and fellowship with two different types of mast cell disease. To get an idea of how different the patients can be and how they can present differently. So the first is a 50-year-old man who I saw who was actually from Alaska, and he had pretty bad osteoporosis. He was initially hospitalized for a GI bleed and needed surgery, and then while he was in the hospital, he was being turned by nurses. And because his osteoporosis was so bad, he actually got a couple pathologic spinal fractures and ended up having a spinal cord injury and needed to be transferred to Harborview for neurosurgery. And his baseline tryptase level was greater than 90.
How long into his hospitalization before somebody decided to run the tryptase?
No, so actually, I sort of combined it, but he had actually been diagnosed with Mastocytosis about 20 years earlier, and at the University of Washington, and decided he didn't believe he had mastocytosis and went back to Alaska and didn't get any treatment, and then this happened. But he did have another tryptase level during this hospitalization. I think it was still like 80 or 90, so still fairly high. The second case is a 40-year-old woman with episodes of flushing and pruritus that was worsened by strong odors. Her baseline serum tryptase was 4, and then it increased to 7 during an episode, and her symptoms improved with cetirizine and ketotifen. So you can see how these two patients are very different, but both have different types of mast cell disease. So just to go through the pathophysiology a little bit, so mast cells are found in all tissues, but particularly high numbers in the skin, the respiratory tract, the GI tract, and around blood vessels. And this makes sense if you think about the symptoms that people tend to get when mast cells are activated tends to involve these organ systems. And when they're activated, they release various mediators that lead to the symptoms. And serum tryptase is a good marker of mast cell activation, so that's the lab test that we really rely on in clinic to figure out if patients are having symptoms of mast cell activation. So mast cells arise from progenitors in the bone marrow, and they rely on this growth factor called stem cell factor that's important for the normal development and growth of mast cells. Mast cells express a receptor for this called c-KIT, which is a transmembrane tyrosine kinase, and that's encoded by the KIT gene. Many of the defects associated with mastocytosis, especially systemic mastocytosis, involve a mutation in c-KIT, which leads to pathologic accumulation of mast cells in various tissues. And I think something like 80% of patients with systemic mastocytosis will have a c-KIT mutation. And the most common mutation is a point mutation at codon 816. So this is just a picture of a mast cell. Here in purple, you can see the IgE molecules bound to it, and then the antigen in yellow. So the antigen binds the IgE and leads to cross-linking, and then the mast cell degranulates and releases its various mediators. And here's a table just with some of the mediators and the symptoms that those mediators cause. And here you can see it's a pretty wide variety of symptoms that people can get. So the things that are released are histamine, which can cause hypotension, and vasodilation, tryptase, which is that lab that we check, prostaglandins, platelet activating factor, cytokines, leukotrienes, and chemokines. Here is just kind of a table I put together of the symptoms that patients can get with mast cell activation. You can see almost every organ system can be involved. So in the skin, you can get actually infiltrates of mast cells leading to various lesions. You can get flushing pruritus like that patient I mentioned earlier. Anaphylaxis. Patients with mast cell disorders are particularly susceptible to anaphylaxis from Hymenoptera. Stings. Cardiac symptoms and respiratory symptoms, shortness of breath, wheezing, hypotension, tachycardia. A lot of patients have GI symptoms, chronic abdominal pain, nausea, vomiting, diarrhea, peptic ulcer disease, or GI bleeding. Patients can have neuropsychiatric symptoms and complain of depression and mood changes and irritability, and fibromyalgia-like symptoms. They can get osteoporosis and osteopenia, like that first case, the patient I talked about. They can get lymphadenopathy, splenomegaly, and hepatomegaly, and organ dysfunction from those. So you can see that really the symptoms are so varied, it's really hard to diagnose mast cell disorder or mast cell disease just based on the symptoms because it can be very different in different patients. There are specific triggers that tend to trigger mast cell degranulation, especially in these patients. They can be susceptible to opioids, NSAIDs, contrast, vancomycin, muscle relaxants. A lot of times physical stimulation, pressure, temperature changes, spicy foods, or strong odors like that patient I mentioned earlier can trigger symptoms. Surgeries, alcohol, infections, and stress can be other symptoms and triggers, and Hymenoptera stings again, which I'm going to talk about a little bit more. So the two main triggers of anaphylaxis in patients with mastocytosis are idiopathic anaphylaxis and Hymenoptera stings. And just some numbers that I took from some articles. So 7 to 8% of patients with a systemic reaction to Hymenoptera venom will have mastocytosis. And out of all the patients with mastocytosis, 5 to 19% of them will have a Hymenoptera systemic reaction. And then if you take patients with mastocytosis, once they're stung once, if they're stung again, 50% of those patients will have a severe reaction on the second sting. And frequently, these patients will have cardiovascular compromise, they'll have syncope, hypotension. It's not just subtle symptoms usually, and so it can be very severe. And something else to point out is that up to 15% of these patients may have negative serum IgE. And so it's actually been reported that in general, patients with mastocytosis have lower total IgE and specific IgE levels. The reason being is that the IgE, because you have more accumulation of mast cells and tissues, more of the IgE is bound to the mast cells, and there's less in the serum. And so you have to take these patients very seriously, and even if they have a negative specific IgE, you really have to consider whether they had a true systemic reaction if they bring that up. And you should always be asking patients about insect sting reactions.
Point about, go back for a second, the 50%, what time frame of the subsequent sting? Because people without mastocytosis, it's often said, that's 70%. So I'm not sure that's any different.
Yeah, I don't know. The article didn't really specify how that's different from the general population of people who are stung a second time.
Jamie, is there any speculation, assuming they don't have obvious specific IgE, any speculation about how it activates mast cells? I mean, complement receptors, other
I
It just
didn't
seemed-
find,
yeah,
there are
it
a
was
lot
just-
of
it's
articles
always-
about it, and there's clearly an association, but I didn't find a whole lot that actually talk about why this is a particular trigger
Yeah,
in
just
mast cell
curious.
mutations. I
I've
don't know if
always
anyone else.
thought it's because the Hymenoptera, I mean, they contain a fair amount of B venom melatonin and specific phospholipases that directly cause mast cell degranulation. When you have such a marked increase in mast cells, then a small amount of the secretagogues there and the venom is sufficient to induce the
So
anaphylaxis.
just sort of the enzymatic effect of the. Gotcha.
And they're twitchy, they're
Right.
activated mast cells, so they're geared to degranulate with any kind of
It doesn't
stimuli.
take much, right?
Yeah. So because the symptoms are so varied and can be nonspecific, there's a pretty broad differential diagnosis of things that you should be thinking about too when you're considering mast cell disease. So just some things that should kind of be on the list. So carcinoid syndrome can cause flushing, abdominal pain, diarrhea. You'll see here that a lot of the symptoms are flushing and GI symptoms, which tend to be pretty prominent. So hereditary angioedema, it's a little different, obviously, with episodes of swelling, but patients can get episodic abdominal pain as well. With a PHIO, patients can get flushing and headaches. VIP secreting tumor can cause chronic diarrhea. Medullary thyroid cancer can cause flushing and diarrhea. And then there's this other population of patients who can have elevated tryptase levels and don't have mast cell disorder, but have something else called hereditary a-tryptasemia. And so when you're seeing patients with maybe some symptoms of mast cell activation, but don't fall under the other mast cell disorders and do have elevated tryptase levels, you should think about this. I'm going to talk
In
about
that last condition, where's the tryptase coming from?
what?
Where's the tryptase coming from in that?
Oh, I'm going to talk about it.
Oh, okay.
So this is a paper, I think from 2016, by Josh Milner at the NIH, where they described family cohorts. There were 96 patients from 35 families with elevated baseline tryptase levels. And these patients didn't have mastocytosis. They didn't meet any of the criteria for mastocytosis. But they did have some sort of consistent symptoms that I'll go through in a little bit. And they found that the symptoms and the elevated tryptase levels were associated with an increased copy number of this gene, TPSAB1. So the symptoms that the patients had, some of the symptoms were similar to the mast cell disorder patients, so flushing and itching, some chronic GI issues, and reactions to insect stings. But one thing to point out that was a little bit different is that they tend to have joint hypermobility and presented more of like an Ehlers-Danlos syndrome, and this really isn't seen in mastocytosis. So if someone's coming in with a concern for mast cell disease and they have some joint hypermobility, you should think about this as well. And they found that this was autosomal dominantly inherited. So
Go back for just.
yeah,
Ehlers-Danlos 3, does that mean there are 3 variants of that?
yeah, there are different variants.
There's like
So,
9. There's
There's 3.
yeah.
Four's the
Do
best.
you know how they differ?
I didn't go through that.
All right.
But yeah, so first they did exome and genome sequencing of these patients, and they didn't really find any like shared or common variants. And then they did linkage analysis, and they found this gene on the human tryptase locus. There were 2 genes, the TPSAB1 and TPSAB2, that encoded for alpha tryptase or beta tryptase. And they found in these patients elevated alpha tryptase to beta tryptase ratios. And they found that the alpha tryptase, the TPSAB1 gene, there were multiple copies that were inherited together on the same allele, could be inherited together. And these patients that were affected had an increased copy number. And so the people that had a single copy on both alleles, they were normal. They had normal basal tryptase levels, and they didn't have symptoms. And then patients who either had a duplication on one allele or both alleles, or a triplication, so 3 copy numbers on one allele, had higher tryptase levels, and this was also correlated with the clinical severity. So, and I'll go through this in a minute, but the patients with a triplication, so 3 copy numbers, tended to have more symptoms than the patients with 2 copy numbers.
When we measure a tryptase, do we measure both alpha and beta combined? Is that the current assay, and then you have to split it out into the 2?
I think so. I think it's just total tryptase. Yeah, so we don't usually get in clinic like alpha tryptase or beta tryptase. We just get the total tryptase. So these are some of the symptoms that they found in these patients. The first column is just all the patients that they identified with this hereditary alpha-tryptasemia, and then they divided those patients up into either duplications or 2 copy numbers or 3 copy numbers, a triplication. And you can see in bold a lot of the symptoms, not all, but a lot of the symptoms, the percentage of patients with the symptom went up with the 3 copy numbers. So for example, if you look at the second line, flushing or pruritus, 45% of patients with 2 copies had this symptom, flushing, but 80% of the patients with 3 copy numbers had the symptom. Sort of similarly, if you look under the fourth line, chronic GERD, 49% of the patients with 2 copy numbers had that, but 100% of the patients with 3 copy numbers had that. So again, not all the symptoms went up between the 2 groups, but a lot of them did. And then this is a chart looking at the tryptase levels on the y-axis, and then the copy number on the x-axis. So the white circles are the normal patients without the hereditary alpha-tryptasemia, and then the black dots are the hereditary alpha-tryptasemia patients.
Do they present in childhood just because the genetic?
They didn't really say. They just said that they found these patients in 35 families, but they didn't really, say what ages the patients were that they found. I sort of imagine since they were 96 patients from 35 families, there was some patients in different generations in the same family since it's autosomal dominantly inherited.
What were the skeletal abnormalities?
They didn't say. They just said skeletal abnormality. They didn't go into a lot of the specifics. So you can see here that the patients with the 2 copy numbers had elevated tryptase levels compared to the unaffected patients, and then the patients with 3 copy numbers all the way on the right had higher tryptase levels than the patients with 2 copy numbers.
So these people all had bone marrow biopsies to say they did not have typical mastocytosis?
I imagine so. They just said the patients didn't have mast cell disease, but they didn't say how they knew that. I imagine that they went through the clinical criteria and they didn't meet any of the clinical criteria. Yeah, I'm going to go through it, so you're going to, you have to have a biopsy. So.
Did anybody, I had a patient some time ago and for the first time learned that there's this whole internet concern of sort of invalid people who think they have Ehlers-Danlos syndrome and mast cell disorder. There's
And POTS, too.
And POTS,
And
yeah.
POTS.
Yeah.
Well, it's a
So
whole-
I don't know if this is the paper that led to, well, this paper's from 2016, it's fairly recent.
It was out there well before that.
Well, it's
Yeah,
the,
this concept.
This whole concept.
it's the whole blending of that with like dysautonomia, or like everything is sort of neurologically out of whack. That's sort of a gray zone.
There's a hand surgeon in Mount Lake Terrace who's really popular with the Ehlers-Danlos folks because he does a lot of their joint reconstructions, and he sends every one of them to me to make sure they don't have mast cell activation disorder. So I tell him, why don't you just order your own tryptase? You don't really have to send anybody here, but he keeps sending them anyway.
And just for your knowledge, there's a guy here at the U who's an expert in collagen disorders, all the things that cause hypermotility. Peter Byers, if you need somebody good to evaluate these people.
What
Go
division
down
is he in?
Is he?
Yeah.
Yeah.
What
Well,
division is he?
call him up and
Genetics.
Genetics?
Yeah, he's in medical genetics. He's a really smart guy.
Does he have an outpatient clinic where you can send people in?
He does, but there's a real backup to see
So
him.
it's months to get
Well,
in.
he has some colleagues that work with him in medical genetics.
There was Mitzi Murray who used to be here. She's left. She's the other one that used to see this all the time. So.
How did anybody know how this whole scenario got? Sorry to distract you here, but got created. This whole concept of Ehlers-Danlos and mast cell disorder.
And
Where the genesis of this all came from?
I met with Peter about this. And we don't know. We just think it's because the overlap of all the symptoms and so many different organ systems being involved, in these disorders. But yeah, I met with Peter about this. We don't really know how this came about.
These patients spend a lot of time with doctors.
Is this a regional thing or is this national?
National. I remember having patients going in residency going back and forth between LA and Washington, D.C. with different experts in Ehlers-Danlos. Definitely national.
Right, I guess just to be aware of this.
Jamie, on this one, I'm still confused of where the tryptase is coming from. She's presuming mast cells are the only cell in the body produces it. Are these the mast cells in these individuals just pumping out triple the amount of tryptase?
Yeah, so basically the
Same
gene
number,
that
but-
encodes the tryptase has increased copy number, so they're just producing.
So
A
they
lot
must
more
be
tryptase.
unstable to get all these symptoms. It's not like they're quiescent mast cells just happy in the tissues.
Yeah, I mean, because they have symptoms. I mean, they don't have like mastocytosis, but they certainly have other symptoms. They're not just healthy people.
So you would
without-
think you would show signs of, like on a bone marrow, they'd be activated. You'd have signs of mast cell degranulation or other mediators, histamine there.
Yeah.
Or
They-
did they go into any?
They didn't go into that, yeah. And they didn't mention anything about biopsy in this paper about the patients getting bone marrow.
I mean,
It's hard to
the-
believe that you could just make a statement they didn't have mast cell disease and leave it at that. And then define a new syndrome and get it in a world-class paper, a journal.
Yeah.
Well, it's a good question. I mean, does the level of tryptase that you make influence receptor responsiveness? I mean, they could easily measure that, I would think. Right? Just trigger the mast cells and see, compared to somebody else.
Yeah, they must be heightened response. I don't know.
Right. I mean, see KIT may be normal, but no.
So now I'm going to go into more of the sort of typical mast cell disorder. So for the rest of the talk, I'm going to talk mostly about the primary mast cell disorders and then also touch on idiopathic mast cell activation syndrome because it's something that comes up frequently. So the mast cell disorders can be classified into three main groups. Primary mast cell disorders, which includes mastocytosis, either systemic or cutaneous, and then monoclonal mast cell activation syndrome, which I'm going to refer to as MMAS because it's too long to say. And then there are secondary mast cell disorders, which I'm not going to really talk about, but these are disorders where mast cells are activated from some other driving cause, and the mast cell activation is really secondary from like allergic disorders, physical urticarias, or some neoplastic disorders that drive mast cell activation. And then there's the idiopathic group, and I'm going to mostly talk about the idiopathic mast cell activation. So mastocytosis is when you have increased number of mast cells in one or more tissues. And as I mentioned earlier, many patients have this c-KIT mutation, which leads to clonal expansion and pathologic accumulation of mast cells in tissues. And there are two main types, cutaneous or systemic. Cutaneous is only involved in the skin. Systemic may involve the skin, but it also has to involve other organs as well. Cutaneous mastocytosis is more common in children. It usually presents within the first year of life and usually resolves by adolescence. Versus systemic mastocytosis usually presents in adults and usually is persistent once someone has it. It doesn't usually go away. And I'm going to talk about the different types as well later on. So cutaneous mastocytosis, the diagnostic criteria, you have to have typical skin lesions. And then on biopsy, you have to have infiltrates of mast cells. And then you can't fulfill the other criteria, systemic mastocytosis, which makes sense. So there are three main types of skin lesions. So the most common type is Urticaria Pigmentosa, where you have just sort of diffuse infiltrates of mast cells in these lesions. And as you can see here, there are a lot of different ways it can present. They can be flat, they can be raised, they can be brown, tan, they can be skin color. So they can look very different in different patients. So it's it's something to kind of be aware of and do a good skin exam. And then there's diffuse cutaneous mastocytosis, where there's really just kind of diffuse infiltration of the skin with mast cells instead of discrete lesions. And then there's mastocytoma, which are just one or a couple isolated areas of mast cell infiltration as opposed to kind of all over the body. And then systemic mastocytosis is 6 different categories, and I'm going to go through these a little bit later, but they kind of go from least aggressive, indolent systemic, to more aggressive, going down the list. But in order to diagnose someone with any of those types of mastocytosis, you first have to fulfill the criteria for systemic mastocytosis. So the WHO criteria are patients either have to have 1 major criteria and 1 minor criteria, or 3 minor criteria. There's only 1 major criteria, so on biopsy, patients have to have multifocal dense infiltrates and mast cells greater than 15 in aggregate. And it has to be on a biopsy of bone marrow or other extracutaneous organs, so it can't be in the skin. And then there are 4 minor criteria. So the first one are basically mast cells that are abnormally shaped. The second is this activating mutation at codon 816, the c-KIT mutation. The third is abnormal markers of mast cells. So CD2 and CD25 are not usually on mast cells. And so in these patients, they can be abnormally expressed on mast cells. And then the last one is a serum total tryptase level greater than 20 persistently. So as you can see here, I pointed out that for most of these criteria, except for the tryptase, you need a biopsy, and it can't be a skin biopsy. And so you really do need, usually it's a bone marrow biopsy to diagnose systemic mastocytosis. And the only criteria that we can really fulfill in clinic is this tryptase level, and that's why we rely on it so heavily to help figure out who should we send for a bone marrow biopsy and who we shouldn't. So monoclonal mast cell activation syndrome, MMAS, is that other primary mast cell disorder. These patients have symptoms of mast cell activation, and they meet some of the criteria on biopsy, but not all of the criteria. So usually these patients either have the c-KIT mutation or abnormal markers on the mast cells, but usually their tryptase level is less than 20. It's usually not quite as high as in systemic mastocytosis, and they don't otherwise fully meet the criteria. But they do have abnormal bone marrow biopsies. And then there's that idiopathic group, the idiopathic mast cell activation syndrome. These patients have signs and symptoms of mast cell activation, just like the other patients, but they really don't have any evidence of abnormal mast cells on biopsy. So there are these proposed diagnostic criteria, which you probably can't see very well up in the corner, this paper, but we use this to diagnose idiopathic mast cell activation. So the criteria are that patients have to have symptoms of mast cell activation, they have to improve with treatment, and then the only objective criteria is that their tryptase level has to increase 1.2 times their baseline tryptase plus 2, or they have to have an elevation in urine prostaglandin 2 in a 24-hour urine during a symptomatic period. Because it's a lot easier to send someone to the lab to get a tryptase level checked and then check a 24-hour urine. We really, I haven't seen that be used at all, that second criteria. So usually we send someone to the lab, we give them a lab slip and say, come back to the lab when you're having symptoms, and we check their baseline tryptase and when they're having symptoms to see if it goes up appropriately. And then again, they can't meet the other criteria of systemic mastocytosis. And again, these patients would have normal biopsies. And here it's just from that article, the diagnostic criteria. And just to point out, they have to have symptoms that involve 2 or more organ systems, so it can't just be one organ system that they're having symptoms. So here's just a little chart from UpToDate about those different types. They also have idiopathic anaphylaxis in here. And just to point out a couple differences that I mentioned, so the baseline tryptase usually is the highest in systemic mastocytosis. It's usually greater than 20. It tends to be normal or mildly increased in MMAS or the idiopathic mast cell activation. And the 2 main differences between those 2 groups, the systemic mastocytosis and the MMAS versus the idiopathic, is they tend to have in green the c-KIT mutation or the aberrant markers, the CD25 on mast cells, versus in the idiopathic group, they really don't have those two findings. Again, this is just kind of the chart to make sure we kind of know where we are. And then, so there's this paper that I wanted to talk about that looked at the clinical characteristics of patients with the primary mast cell disorders compared to the idiopathic group to help figure out which patients, what are the clinical characteristics that can help figure out which patients will have an abnormal biopsy and which patients are more in that idiopathic group and what have normal biopsies. And so this article is very helpful if someone comes into clinic and try to figure out what are the characteristics that would make us think someone should go to biopsy or not. So they looked at 83 patients with symptoms of mast cell activation, and then they had the patients undergo biopsies, and they put them into two groups. On the right is, they classified as indolent systemic mastocytosis, but they define that as the c-KIT mutation and abnormal markers, this abnormal CD25 on the mast cells in biopsy. And so, just to point out, 94% of these patients met the WHO criteria for systemic mastocytosis, not all of them. And I think that's because they were including some of the MMAS patients as well that would meet some of the criteria, but not all. And then they divided on the left side patients who had basically normal biopsies, that idiopathic that they called the non-clonal group.
So left and right, backwards.
Oh, sorry, left. On the left. So these patients didn't have the c-KIT mutation, and they didn't have any abnormal markers in their mast cells on biopsy. And so then they looked at a bunch of different things. They looked at gender, they looked at symptoms, tryptase level, some other lab markers to see if they could figure out differences between these groups. So the first column, the NC, MCAD, those are the idiopathic group with normal biopsies. The middle column, the ISM, and it says S negative. I don't know if you can see that, but those are patients with primary mast cell disorders, but without skin involvement, so skin lesions. And then the third column, it says S plus, and those are patients with skin lesions. And I don't know why they divided up the groups like that, but so just a couple things that I pointed out in blue. So there was a pretty big difference in the gender between these groups, and so there were many more patients who were male who had the primary mast cell disorder, so those second two groups compared to the idiopathic group. And then the second thing in blue that I pointed out is pruritus. Just to point out, between the two groups with the primary mast cell disorders, the patients with skin involvement had much more pruritus than the patients without skin lesions. And it makes sense, if you have mast cell infiltrates in your skin, you're going to be itchier. And then the tryptase level, the last one I pointed out. So patients with the primary mast cell disorders had higher tryptase levels than the patients with the idiopathic group. And so then they looked at what were the different triggers for these patients. Were there differences in what were triggering symptoms? And so some of the triggers that they looked at weren't really different, but they did find two things. So in the primary mast cell disorders group, they tended to have more reactions to insect stings, versus the idiopathic group, they tended to have more reactions to drugs and medications. And then they looked at the various symptoms that the patients were presenting with, and again compared the two groups to see if there was a difference in what symptoms they had. And a lot of the symptoms weren't different, but there were a couple that were statistically significant between the two groups. And so the idiopathic group tended to have more urticaria, more angioedema, more dyspnea, versus the primary mast cell disorder group tended to have more syncope and presyncope and more real cardiovascular collapse. And then here are two charts basically just saying the same thing. Table 3 is the primary mast cell disorder group. The lower table is the idiopathic group. And again, just presenting it differently, but the primary mast cell disorder group, they tended to be male, have more syncope, have insect venom be a trigger, and a serum tryptase level greater than 25, versus the idiopathic group, they tended to be female, they tended to have more urticaria, angioedema, dyspnea, have drugs be a trigger, and have a lower serum tryptase level. So based on this, they came up with this REMA scoring system that we use in clinic to help figure out which patients are at risk for primary mast cell disorders and have abnormal biopsies versus which patients tend to be in that idiopathic group. So based on the findings that they found, they divided them into 3 groups: gender, clinical symptoms, and tryptase level. And then they, you add them up and basically give them a score. Any score greater than equal to 2 was a higher probability of a primary mast cell disorder. And those patients, they recommended, should get biopsies. So now I'm just going to go through the different types of systemic.
Have you seen anything where they tried to look at differences between the mast cells in these groups, try to get more biochemical differences? Because there's this, some mast cells are the chymase, tryptase, the CT mast cells.
Yeah, I didn't.
It could be a clonal expansion of like tissue mast cells versus mucosal mast cells. That could create some of these differences. Or
yeah, I didn't find that. They just looked at.
You would isolate those fairly readily, or you could do gene arrays to see differences in their biochemical pathways, the cytokine receptors or production. You could isolate them from the bone marrow, do a fairly groups to get kind of a more definitive separation of these groups. It always seems so confusing to try to conceptualize how these are different.
Yeah.
Here's another question for you. I've always had a problem. What's the difference between idiopathic anaphylaxis and idiopathic mast cell activation syndrome?
Yeah, so
virtually identical.
So idiopathic anaphylaxis is when patients are having anaphylaxis without a clear trigger. In the idiopathic mast cell activation disorder, remember you have to have 2 organs involved. So I think you have to have, from what I could tell, is you can have idiopathic anaphylaxis, but you have to have something else, not just that. So if you just have episodes of anaphylaxis, I think it just falls in the idiopathic anaphylaxis. But if you're having some other symptom that goes along with that, that could be a symptom of mast cell activation, you would fall more in the idiopathic.
Most people with idiopathic anaphylaxis are going to have 2 organ systems involved.
Right.
They can have their skin and certainly something else, respiratory or...
Mast cell activation usually have more symptoms in between the episodes, and that's how I've seen it kind of grouped. I agree that it's fluid.
Yeah,
it's the idiopathic anaphylaxis, in my experience, they just have these finite severe episodes, but they don't have a lot of symptoms in between those episodes, whereas the mast cell activation, I've seen it grouped, they have more daily symptoms, at least in my experience. But again, the diagnosis is fluid.
How much trouble are you continuing to have with crazy people who have none of this?
A lot.
Yeah, like half of the patient.
Both of them.
Half of the patient.
A lot.
Half of the patient.
No, thank you.
All right. So now I'm going to go through the different types of systemic mastocytosis. So once someone meets criteria for systemic mastocytosis on a bone marrow biopsy, then you have to figure out which kind of a category they have. And so that's based on these B findings and C findings. Basically, the B findings are organ involvement but no organ dysfunction. And then the C findings denote some type of organ dysfunction and have a poor prognosis. And here you can see some of the C findings are cytopenias, thrombocytopenia, neutropenia, anemia, liver dysfunction, thrombocytopenia from splenomegaly, pathologic fractures, or some other type of organ damage from the mast cell infiltration. So indolent systemic is the most common type of systemic mastocytosis and also tends to be the least aggressive. So these patients have 0 to 1 B findings but no organ dysfunction. The smoldering systemic, these patients tend to have more organ involvement, so 2 or more B findings, but still no organ dysfunction. And these patients have higher rates of progression to more advanced disease, so you do have to watch them a little bit more closely. And then aggressive systemic mastocytosis, these patients have C findings, so they do have some type of organ dysfunction related to their mast cells. And then this is much more rare and has a poor prognosis. And then the other ones really are more kind of within the hemonc realm, so associated with the neoplasm, mast cell leukemia, or mast cell sarcoma. So mast cell leukemia patients tend to have circulating peripheral mast cells, like blasts,
When you say these cells evolved, they evolved down this systemic mastocytosis pathway or into other diseases?
Down the pathway. So you can go from like indolent systemic to smoldering. Yeah, exactly. And the mast cell sarcoma is basically a malignant growth of mast cell tumor. So this is a pathway to just kind of help figure out if someone comes into clinic with symptoms of mast cell activation, how to diagnose them and how to figure out which patients go to biopsy and just kind of like group them in your head. So the first thing that we should be doing is getting a tryptase level. Again, that's the only thing we can really get in clinic to help with the diagnosis, because that's sort of one of the objective things we can get. So if someone has a tryptase level greater than 20, all those patients should be going straight to hemonc for bone marrow biopsies. And then on the biopsy, if they meet criteria for systemic mastocytosis, that WHO criteria, then you have to figure out which subtype they have based on their BNC findings. If you send them to biopsy and they don't meet criteria for systemic mastocytosis, but they do have some abnormal mast cells, so they either have that c-KIT mutation or the CD25 positive marker, then they have that MMAS. And again, those two are the two primary mast cell disorders, the clonal disorders. And then if they don't have any symptoms of mastocytosis or primary mast cell disorder on bone marrow biopsy, then they kind of get shunted in the other pathway. So if their tryptase level is less than 20, then you use that REMA score that I talked about, which is based on gender, clinical characteristics, and the tryptase level. If their REMA score is greater than 2, those patients should also be going to biopsy because they have a higher risk of the primary mast cell disorders. And if their REMA score is less than 2, that's when you should give them a lab slip or put in a lab order for tryptase and say, come back when you're having symptoms, to help figure out if they're more in this idiopathic mast cell activation group. And if their tryptase level doesn't go up enough to be in this idiopathic mast cell activation group, then they either don't have one of these mast cell disorders, and that's when you should be thinking about the other sort of differential things that can cause symptoms similar to these disorders. So just to go back to the cases that I talked about at the very beginning to kind of figure out where these patients would go and what they'd be diagnosed as. So the 50-year-old with osteoporosis, he had a GI bleed, he had a pathologic fracture and a spinal cord injury, and his tryptase level was greater than 90. So if you were to send him to get a tryptase level, his tryptase level was greater than 20 by far, he would go straight to biopsy. He actually did have systemic mastocytosis, and if we were to then kind of try to categorize him and figure out which subclass, which type he has, he actually had the c-KIT mutation. So he had a pathologic fracture, so that counts as one of the C findings, which is organ dysfunction, and so he would have aggressive systemic mastocytosis, which again is rare and has a poor prognosis. And he actually got started in the hospital on bisphosphonate and interferon alpha, and hemonc actually wanted to treat him with chemo as well. The second case that I talked about, the 40-year-old woman with facial flushing and itching, her baseline tryptase was 4, and then it rose to 7 during an episode, and her symptoms improved with cetirizine and ketotifen. So her going down the pathway, her tryptase level less than 20, so then you would do the REMA score on her to figure out her risk. And so if we do her REMA score, I actually did this incorrectly. So she's female, less than 1. Actually, I said she had urticaria, but then I realized she didn't. So it should be absence of urticaria angioedema plus 1, so her score is 0, and then her tryptase level is less than 15, so her score should be -1, not -4. But regardless, it's still not greater than 2. She still falls within the same category. She's a low risk of having a primary mast cell disorder. And so you wouldn't send her to biopsy. You would give her that lab slip and say, come back when you're having symptoms. And so her tryptase level did go up enough during the symptomatic episode, so it went from 4 to 7. And so she was diagnosed with idiopathic mast cell activation. And again, her symptoms did improve with treatment, which is part of that clinical proposed diagnostic criteria. And so just to briefly talk about the treatments, the treatment really is aimed at the symptoms of mast cell activation that the patients are having. It can be pretty varied from patient to patient depending on what symptoms they have. So if patients have anaphylaxis, they should obviously get an EpiPen. For recurrent anaphylaxis or idiopathic anaphylaxis, there is a role for Xolair. And then if they had a systemic reaction to Hymenoptera venom, the recommendation is for lifelong venom immunotherapy. These patients, as I mentioned earlier, have a higher risk of having a cardiovascular collapse or hypotension or syncope from systemic insect sting reactions, so they can be very severe. And there have been reports of patients being on VIT for 3 to 5 years and stopping and then having a fatal reaction if they're stung again. And so these patients really should be on lifelong therapy.
What do you do if you can't detect the specific IgE?
Yeah, that's a good question. So I don't know. I mean, what I read, it basically said if they have elevated IgE, you should. But there were also some papers saying that you should lower the IgE cutoff criteria, the actual cutoff number to include more patients if they have systemic mastocytosis. And I don't remember what the exact number were, but they basically lowered the IgE level to be inclusive of more patients with mastocytosis.
The problem is there are some people who have been skin test and specific IgE negative, and you don't know what to do with them. You can't put them on a venom that you can't diagnose. The other thing is, what's the mechanism? You really haven't talked about IgE in this talk at all, so how does Xolair work?
Xolair?
Yeah.
Downregulates mast cells.
What's the role for Xolair? Is it an IgE disease?
Yeah,
Just like urticaria.
Yeah.
Urticaria is not an IgE-mediated disease.
Well, it's
It's
with
affecting the
chronic
mast
use.
cell.
With chronic use, it downregulates mast cell releasability. But that doesn't explain urticaria patients getting better after one shot. That takes a while. Bill's working.
Trying to figure it out.
You're working on that, right? But yeah.
Got a bunch of mice with hives.
Pardon?
Got
No,
a
we
bunch
have
of mice with hives.
We have people with hives.
He's doing it in his mouse.
That's right.
Drew, you've gotten a number of people with this disease approved for Xolair.
You've done very well on it.
Yeah, I know
not
they do well
universal,
on it, but getting insurance approval.
I haven't had a problem. These patients are being seen so frequently.
Even ones without skin lesions, without hives or itching, you've gotten it approved?
No matter what their IgE level.
Yeah, for urticaria.
Most of them have urticaria.
Yeah, I was going to say that.
But I've gotten a few. For the most, the majority have that.
Yeah.
Where do you guys get your Cutaneous? Do you have a protocol for compassionate release? You just send them to Canada and get it in Canada?
I don't know, actually, I haven't
She hasn't
prescribed
done
it.
it.
I send them.
She's telling us
There's a website in Canada. I send them
There
to.
are a lot of websites.
There are a lot of
in
compounding
Canada.
pharmacies that'll do it
I was
around
gonna
here
say.
as well.
Or if you have any of these patients,
mail orders it to
if you have
us.
any of these patients, they'll tell you. There's a compounding place in Portland that does.
All kinds of
Yeah.
stuff.
You know, I used to use just one Canadian website, drsolve.com, but I can't remember what it is, but there's one website that lists every non-U.S. pharmacy where you can get meds, India, UK, Australia, New Zealand, Canada, and comparative prices. One of the staff over in our Redmond office showed me that. Trouble is I can't tell you the name of the website, but I'll try and find it.
There's some awfully inexpensive generics in Canada compared to
Yeah.
what we have here. So,
So just to kind of keep going through this, if patients know what their triggers are, like some of those physical triggers, they should try to avoid them. For skin symptoms, you can use oral antihistamines, oral Cutaneous. For GI symptoms, H2 blockers, oral chromal sodium. Montelukast can help with some of both the skin and GI symptoms. And then if they have osteoporosis, they should be on vitamin D and calcium. And if they have fractures, the recommendation is pimidurnate and interferon alpha, like that patient I talked about. If they have extensive cutaneous disease, phototherapy can have a role. And then for the more aggressive forms of mastocytosis, they should be treated by an oncologist, and there are roles for chemotherapy and cytoreductive treatments.
Does it work? Does the chemotherapy work?
I don't know. I mean, the patient that I saw, they wanted to, and I mean, it's recommended. I haven't had patients.
I just
that
wonder.
had
I have
more
never
aggressive
seen
forms.
data on that about chemotherapy for it and how effective it is. I'm just curious. Of course, I don't see many patients like this either. Bill, have you seen people with systemic mastocytosis that respond to chemotherapy, and what did they use? I mean, you haven't seen it either.
Yeah, we've never had success with that. I was curious if some of the pharma are developing some specific mast cell kinases that target that for mast cell signaling. Have you seen any case reports where they've used that compassionate use? Because there's some tyrosine kinase very specific for mast cell signaling that are a good pharmacological target. This would be a good situation to use them in.
And then anyone with mastocytosis, you should monitor them yearly just to make sure they're not progressing. So kids with cutaneous mastocytosis, you should be getting CBCs, LFTs, tryptase, just to make sure they're not progressing to systemic mastocytosis. And then in patients with systemic mastocytosis, you should be getting the same things, making sure they're not getting end organ dysfunction or progressing to the more aggressive forms. And then just keep in mind that these patients should be getting regular DEXA scans too. I think I won't forget that after my patient who had the spinal cord injury from being turned in bed.
Why do kids usually outgrow it?
I don't know why. I mean, those patients, they tend not to have that c-KIT mutation, so I don't know. I didn't read a whole lot about what the difference is, but clearly there's differences in just having the cutaneous form versus systemic, and but
A little more mundane question. Do you know how reproducible the tryptase assay is?
That's a good question.
the tryptase.
Yeah, we're relying on pretty small numbers to make a distinction between normal and this syndrome. So, how sensitive is that assay?
Yeah, I mean, I don't know. I think it tends to be, like I've seen in clinic, be pretty reproducible. But, I mean, if patients have a really high tryptase level greater than 20, those patients, I mean, there's a, you're talking about the idiopathic mast cell activation.
4 and 7.
Yeah.
A distinguishable difference in that assay.
Ours is really reproducible in my experience. They started running it in-house a couple of years ago. And it's incredible how often it comes back at the same number, 0.1 or 0.2, sort of what you've had previously. So ours is pretty good in my experience.
Is there any utility in doing bone scans on these people before you bone marrow biopsy them to selectively biopsy hot tissue, or is that not utilized in this diagnosis? Because there's a lot of decisions made on the bone marrow biopsies, so if you could find a hot piece of bone marrow, that may be changing what we do for these folks.
I mean, I sort of imagine if it's in one part of their, I imagine they're just doing standard bone marrows the way they do, and everyone just from the iliac crust and not different areas of bone marrow.
And are there any markers that are specific for mast cells only?
I mean,
c-KIT.
c-KIT. Is there a CD number for that?
It's CD117.
And there's antibodies against that, presumably, that you could. I'm not sure we need mast cells for something, but for these people that have really aggressive mastocytosis, they tried CAR T-cell therapy on these folks and just take out all their mast cells.
I think they're in the tissues that you couldn't get them.
They don't migrate out. Lymphocytes don't migrate out.
Bone marrow and just everywhere increased.
I was just curious because these people have the really aggressive disease. If there's a marker in it and a CD number, you wondered if anybody's thought about just taking out all their mast cells and see if that affects the cure or it causes worse disease. Nobody's done that.
No, I didn't find that.
I was thinking if you could target like the microRNA that's leading to the proliferation of these.
Or the tyrosine.
Then you get down-regulate them that way. It seems like there'd be a lot of therapeutic approaches, you should
Yeah.
be trying them.
And it's so specific to one cell. I mean, this is the ideal that we should be able to do something for these folks, just trigger them.
And why is it called C-Kit? That have some meaning?
It's always been thinking. I don't know.
I think it's related to the tyrosine activity. I mean, there's some sort of a. I think there's originally. Is it keratinocyte? Vaguely remember that because you get a lot of these in the skin.
Got this name because we first identified something.
Dr. Frank's Googling it.
Well, that's very
But
thorough.
imagine
You'll
it
see
doesn't
what
work.
exactly.
More or less have to
Right.
do this every year because we don't see enough of these patients to remember, but some of these diagrams are incredibly helpful to think through the process when it comes up.
I admit the majority of patients I see that think they have this have an anxiety disorder, and they usually don't have any of these manifestations and stuff. They're all jumping on the
There's a whole mast cell
bandwagon.
activation syndrome support group.
I know.
On the internet, I'm
Yeah,
sure.
and the neurologists are the ones that are diagnosing this most of the time,
POTS.
and they're
Yeah.
referring
No,
them to
MMAS.
us. And
Yeah, they diagnose
Well,
their POTS. And then they send them
the
to us.
POTS.
I've seen a lot of patients, again, it's sort of this dysautonomia, like their airways touchy, their lungs are touchy, their GI tract's touchy. Yeah, they're kind of
and they're all
woozy.
subjective
brain is
symptoms.
touchy.
Right.
There's nothing
And
objective.
then they get on the internet and it turns into a massive problem.
Mast cell mass.
I guess that's why Al's question is very important.
Yeah.
A tremendous amount of
Right.
this validity of this depends on the accuracy of that tryptase value.
Yeah.
Because most of these people we see have a normal tryptase that doesn't change when they're being symptomatic, and they.
Well, especially with low numbers like 4 or 5, like studying those patients maybe monthly when they're not having trouble. Does it actually go to 7, or in which case then relying on the 20% is not very well.
Larry Schwartz, he had like a JCI paper many years ago when he validated the assay for when they got the commercial preparation. He had lots of patients with a variety of conditions where I can't remember the paper, it was 20 years ago, but it was, what I do remember, it was very clear cut between the different groups, and I think it was used to file to the FDA to get approval for the tryptase assay. So I would assume that there was pretty tight measurements with that, to qualify for a diagnostic test. But that'd be a good paper to check up again.
Who was
Larry
the
Schwartz.
author, you remember?
Pardon?
Who was the author?
Larry Schwartz, who
Yeah.
developed the technique at Medical College, Virginia.
And they used to individually measure alpha and beta at that time, I think. And
Yeah, they were doing that at that time, but that never proved
never panned out to be
clinically useful
diagnostically
to
helpful.
differentiate the two. They just follow total.
It's nice that they
All right,
finally
well,
agree
thank
on
you,
that.
Jamie. Anybody remember what next week is?
It's me.
No?
I remember.
I'm 20 now.
Next
Seems
week,
like-
Oh, your next
I'm
week, what's your topic?
It's primary immune deficiencies, so I'm going to do the adaptive immune deficiencies since Tom had covered an 8 already, and then end with truck screening after
Okay.
that.
Yeah.
This is closer to real world than most of the stuff we've heard. This might have some meat to it.
Huh?
The first 4 days.
Oh.
Jane, are you doing that public speaking thing over the internet? Did you Francis, you-
Yes.
Have you-
It's November.
It's in November?
Yeah.
Oh, okay. I was curious how that was. Fill me in if it's
Yeah,
a
I'll let
useful
you know.
kind of
Yeah.
Sort of-
Block
I
out a
mean,
day for me
we
to
need-
do that.
we sort of think we need mast cells. It'd just be
like a
interesting
4
what
hour
happens if we didn't have
thing.
it.
Right.
Yeah.
I mean, these
Yeah,
guys are
so that's your
giant.
view. I'm sorry.
That'd be the
Yeah,
greatest
that
stuff.
wasn't a good idea.
No, but at least
I wish it was my top next week.
you're gonna die someday.
Yeah, that's too bad.
It's okay. I'll be doing more talks
You
this
have more
year.
time, yeah. Try to schedule one after that. That's all yours.
Oh. Okay.
And then the protocol, you're waiting for Matt?
Yeah, Matt. To review it.
Are you breaking down the room?
That's. You know what? I just started doing it, but I think we'll do it. Take care of it.
So I'd stop by and I've been checking in with the young lady at the front there who's been watching your events for you every week. But I thought I'd just check in with you. How it sounds like everything's been going good.
I think so.
Great to hear. Great to hear.
And so far, it's been very clean. So good. Keep our fingers crossed.
Just out of curiosity, do you prefer this side of the street? All things being equal, do you prefer being in this building? Do you like being here, or just because I'll let you know, in December, for a few weeks, we're going to be renovating the C buildings, so they're going to match the AV capabilities of the here.
That's the building across the street.
Yep. So the original, the first floor